This briefing covers the 2023 expert consensus on the integrated assessment of Shen, our term for the global state of vitality and consciousness. The objective here is to deploy a standardized, quantitative tool that moves us beyond subjective assessment. This will enable reproducible evaluation of patient status across the entire clinical spectrum, from wellness to critical illness.
Our agenda is straightforward. We'll start with the new assessment paradigm, then move into the specifics of the 5-domain scoring system. After that, we'll cover score interpretation and the tiered therapeutic recommendations for each score range. We will conclude with the defined scope of application and, importantly, its contraindications.
All right, Section 1, the new assessment paradigm. The rationale for this guideline is a recognized and critical gap in our current instrumentation. Scales like the Glasgow Coma Scale are optimized for acute, severe neurological deficits. They lack the sensitivity to quantify the spectrum of vitality in conscious patients, including those in sub-health or recovery phases. So, this guideline directly addresses a fundamental assessment dichotomy. On one hand, Western scales provide quantification, but are narrow, focusing only on gross deficits. On the other, traditional Shen assessment is holistic, but lacks standardization, which results in poor inter-rater reliability. This new tool is engineered to integrate that holistic perspective with objective, reproducible quantification.
Moving to Section 2, the Shen scoring system. Let's examine the instrument itself. It's structured as a standardized rubric across 5 key clinical domains. Here is the core assessment tool. It evaluates 5 domains: complexion, gaze, bearing, reaction, and consciousness. Each is scored from 1 to 5, giving us a total score between 5 and 25. Now, a key design feature to note is that the consciousness domain is scored as awake for the top 3 tiers. This is what allows for granular assessment in conscious patients before a decline to somnolence or stupor is ever registered.
Standardized application is absolutely paramount, and it's ensured through these precise operational definitions. Complexion looks at skin color and luster. Gaze evaluates eye vitality. Bearing quantifies overall energy and expression. Reaction measures response speed. And finally, consciousness assesses the level of arousal. Strict adherence to these definitions is critical for reproducibility. Now, within that lowest consciousness score, this distinction is clinically significant. Somnolence is defined as a state where the patient can be aroused by voice and is able to follow simple commands. Stupor, which is more severe, is characterized by arousal only to physical stimulation, with an inability to complete commands. This differentiation is vital for accurately assessing a deteriorating patient. Section 3, interpreting the score categories. We'll now review how the composite score is interpreted, stratifying patients into 4 distinct clinical categories, from present Shen down to lost Shen.
The score interpretation is as follows. A score of 20 to 25 defines present Shen, indicating a healthy state. 15 to 19 signifies reduced Shen, typical of subhealth or recovery. 10 to 14 indicates absent Shen, suggesting significant organ dysfunction. And a score of 5 to 9 defines lost Shen. This is a critical state reflecting organ failure and poor cerebral perfusion, and it carries a severe prognosis.
Let's move to therapeutics. Section 4 covers the recommendations for reduced and absent Shen, specifically for scores from 10 to 19. We'll now detail the management algorithm for patients falling into these categories. The management algorithm is a 3-step process. First, confirm the score is within the 10 to 19 range. Second, you must differentiate the underlying pathophysiology. Is it low organ function or is it organ function dysregulation? Third, select the therapy based on that specific pattern and any relevant comorbidities. For the low organ function pattern, the guideline recommends tonifying agents. Specifically, Jin Kui Shin Chi-Wan is recommended based on evidence that it mitigates brain injury via the PI3K/ATT's signaling pathway. Liu Wei Di Huang Wan is also recommended for its neuroprotective effects, which are mediated by the inhibition of the Fc gamma RIB/CSRC pathway. Now, for the organ function dysregulation pattern, the therapeutic goal is regulation. Jiawei Sha Yawan is recommended as its key components are known to cross the blood-brain barrier and modulate inflammatory pathways. For more targeted gastrointestinal support, Shang Sha Lu Junzi Wan is indicated to improve function and reduce inflammation. In the subset of patients with comorbid cardiocerebrovascular disease, recommendations are tailored to address blood stasis and improve circulation.
Tungsin Lo Jiao Neng is cited for its positive effects on HDL cholesterol and hemodynamics. Shikfu Ju Yu Jiao Neng is noted for its mechanism involving modulation of the HIF1 alpha/NLRP3 pathway in acute ischemic stroke. Section 5, Recommendations for Lost Shen, covering scores from 5 to 9. We are now addressing the management of the most critical category. A score in this range indicates a severe disease state requiring immediate, decisive intervention. Intervention in this category is guided by sharp pattern differentiation. For patients presenting with a heat pattern, An Gong Nu Huang Wan is the recommended agent to clear heat and improve consciousness. For patients presenting with a phlegm damp pattern, Suha Shang Wan is recommended to open the orifices and reduce neuroinflammation. Finally, Section 6, Scope and Limitations. To ensure appropriate clinical utility and prevent misapplication, the guideline explicitly defines the scope of this tool and its contraindications. This tool is designed for broad applicability. It's suitable for assessing healthy and subhealth individuals, as well as for monitoring patients with active disease. This provides a consistent vitality metric that can be used across very diverse clinical settings. The contraindications are explicit and must be adhered to for the score to be valid. The scale is not applicable for uncooperative patients, those with confounding structural damage like facial trauma or severe sensory deficits. Critically, it excludes patients with a diagnosed psychiatric illness, those in a deep coma or moribund state, and patients exhibiting the specific presentations of false Shen or Shen disturbance.
In conclusion, this consensus provides a validated, standardized tool for immediate clinical application. The key forward-looking question is this: how can the digitization of this Shen score be integrated into our electronic health records and then leveraged by AI-driven predictive models to improve prognostication and guide personalized patient management? That represents the next frontier for research and development.